Surveillance after treatment of pancreatic surgery. What does the evidence suggest? Hello, this evidence-based content is prepared by Saboor fellowship-trained consultant surgeon, and if you or someone you care about has completed treatment for pancreatic cancer and you are wondering what comes next, you are in the right place. By the end, you will understand which tests you should have, and when, what the numbers mean, and how to make informed decisions with your medical team about your follow-up care. Post-treatment surveillance means the regular monitoring that happens after you have completed curative treatment for pancreatic cancer. It typically involves periodic physical examinations, blood tests, specifically a tumor marker called CA19-9. It may also include imaging scans like CT scans. There's no agreement amongst specialists yet whether scans are beneficial. The goal is not just to detect recurrence early, but to provide holistic care after pancreatic cancer surgery. This includes well-being, nutrition, enzyme supplementation strategy, and long-term complications from pancreatic surgery. The majority of recurrences after potentially curative treatment occur within the first 2 years. Research demonstrates that when pancreatic cancer comes back, it typically shows up in the liver, lung, or peritoneal cavity. In autopsy studies, approximately 30% had locally destructive disease without distant spread, while 70% had widespread metastatic disease. CA19-9 stands for carbohydrate antigen 19-9. It's a tumor marker that many pancreatic cancers produce. Serial monitoring of CA19-9 levels every 1 to 3 months is useful to follow patients after potentially curative surgery. Rising CA19-9 levels usually precede the radiographic appearance of recurrent disease. An elevated post-treatment CA19-9 increases the risk for recurrence. Mild elevations in CA19-9 can occur with biliary tract dysfunction, which often happens after pancreaticoduodenectomy, that's the Whipple procedure. About 5 to 10% of the population are Lewis negative and won't produce CA19-9 at all, making it useless as a marker for them. If your CA19-9 was initially elevated before treatment, your medical team will likely check it every 3 to 6 months. Now we come to one of the most debated aspects of pancreatic cancer surveillance, whether regular CT scans actually help. The data reveals conflicting evidence, and that's led to very different recommendations from expert groups. The key is that we're not talking about cure here, we're talking about whether finding recurrence earlier before you have symptoms actually extends your life. One study of 216 patients with pancreatic cancer who developed recurrence during surveillance showed that the regimen detected an asymptomatic recurrence in 55% of patients. Median survival was significantly less in symptomatic patients, 5.1 months versus 13 months. Asymptomatic patients were much more likely to receive treatment after recurrence was identified. Analysis of a large national database demonstrated no significant survival benefit for annual radiographic surveillance among patients with curatively resected pancreatic cancer. The key is that we're not talking about cure here, we're talking about whether finding recurrence earlier before you have symptoms actually extends your life. The National Comprehensive Cancer Network recommends a history and physical examination for symptom assessment CA19-9 determinations and follow-up CT scans every 3 to 6 months for 2 years, then every 6 to 12 months. They acknowledge this is based on uniform consensus but a low level of evidence. The American Society of Clinical Oncology suggests visits at 3 to 6 month intervals to monitor for recovery of treatment-related toxicities and recurrence, with tapering after 2 years. If CA19-9 was elevated preoperatively, it can be measured every 3 to 6 months. Many clinicians following ASCO guidelines don't routinely obtain CT scans unless indicated by symptoms or a rising CA19-9 level. The European Society for Medical Oncology emphasizes that there is no evidence that regular follow-up after initial therapy with curative intent has any impact on outcome. They suggest that follow-up visits concentrate on symptoms, nutrition, and psychosocial support, though they do suggest CA19-9 assessment every 3 months for 2 years and abdominal CT every 6 months. The timing of imaging should be determined after discussion with the individual patient, taking into account preferences, level of emotional stress, and concern regarding financial burden. This is explicitly mentioned in clinical guidelines. It's a legitimate part of the discussion. The arguments for early detection of pancreatic cancer recurrence is that CT follow-up may detect disease prior to deterioration of performance status or laboratory abnormalities that might preclude clinical trial enrollment. If you are fit enough and catch recurrence early through imaging, you might be eligible for clinical trials testing new treatments. If you wait until symptoms develop, your performance status might have declined enough that you're no longer eligible. Despite the lack of a consistent survival benefit, secondary benefits for detection of metastatic disease at an asymptomatic stage include early introduction of palliative chemotherapy or radiation therapy to slow disease progression, and for patients who can tolerate an aggressive regimen such as FOLFIRINOX, improve survival. That said, this has to be proven conclusively in trials. For pancreatic cancer, the vast majority of recurrences are not amenable to potentially curative therapy. The evidence that early identification of recurrent or metastatic disease in asymptomatic patients improves long-term survival is limited. Given that there is no known curative treatment for patients with recurrent pancreatic adenocarcinoma, many clinicians do not routinely obtain CT scans in the follow-up. This is when having specific questions for your doctor becomes crucial. You need to understand, what would we do if we found recurrence on a scan before I had symptoms? Would it change the treatment approach? These honest conversations help you decide what level of surveillance feels right for you. Schedule your surveillance appointments in advance. Don't wait for symptoms. Work with your medical team to create a clear surveillance schedule. At each post-surgery visit, focus on well-being, nutrition, pancreatic enzyme supplementation strategy, coping with long-term complications from pancreatic surgery, such as dumping syndrome, risk of diabetes, and risk of infections after removal of spleen. Keep a symptom diary. Track any new or changing symptoms between appointments. Unexplained weight loss, new or worsening abdominal pain, new onset jaundice, extreme fatigue, or changes in appetite. Bring this to every appointment. Understand your baseline CA-19-9. If your CA-19-9 was elevated before treatment, know what level it dropped to after treatment. Any rise from that baseline warrants discussion with your oncologist, not panic but discussion. Address the emotional burden. Surveillance can create anxiety, the scanxiety, before each test is real. Connect with a cancer support group through the American Cancer Society, or ask your medical team about resources for managing the psychological aspects of surveillance. What surveillance schedule do you recommend specifically for my situation, and why? Your tumor stage, nodal status, margin status, and CA-19-9 behavior influence this decision. If CA-19-9 rises or imaging shows possible recurrence, what are the treatment options available to me? Am I a candidate for clinical trials if recurrence occurs, and does that change the surveillance approach? How do my personal preferences about emotional stress and financial burden factor into the imaging frequency decision? This is explicitly mentioned in clinical guidelines. It's a legitimate part of the discussion. New or worsening jaundice, yellowing of the skin or eyes, suggests possible bile duct obstruction from recurrent disease. Severe uncontrolled abdominal or back pain that isn't responding to your current pain management. Unexplained weight loss of more than 10 pounds over a few weeks without trying. Persistent nausea and vomiting that prevents you from eating or keeping down medications. Signs of venous thromboembolism, sudden leg swelling, chest pain, or shortness of breath. Pancreatic cancer patients have a 4 to 7 times higher risk of blood clots than patients with other cancers. Surveillance after pancreatic cancer treatment remains controversial because most recurrences cannot be cured, and early detection doesn't always extend survival, but it may preserve your eligibility for clinical trials and allow earlier introduction of palliative treatments. Your next step: have an honest conversation with your oncologist about which surveillance approach fits your individual medical situation values regarding quality versus quantity of monitoring and emotional tolerance for the uncertainty. I've outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below.